Mr. Ulrich Rosendahl, our very first speaker, who has given up part of his daughter's birthday day to be with us. He's one of the world's leading cardiac surgeons with significant technical and clinical experience in advanced complex cardiac surgery. He operates frequently with Marfan syndrome patients, providing aortic surgery, including PAIRS, the personalized external aortic root support, and mitral valve repair and replacement. After training internationally, he came to us from Freiburg to the Brompton Hospital in 2012. I'm sure some of you are grateful to him already for his expert surgical care. He's going to share with us the options and risks of aortic surgery. And if you have questions, please save them for afterward. Thank you, Ulrich. You have the floor.
Thank you very much, Anne. Good morning, everybody. First of all, I would like to thank the Marfan Trust for giving me the opportunity to give you some insight into the options we nowadays can offer patients with Marfan syndromes with regards to the aortic issues. I will give you a short overview over the possibilities that we have nowadays in our repertoire, and I will give you a bit of a background about the guidelines and where we are standing with regards to preemptive surgery. So I'm a cardiac surgeon, and I'm situated at the Royal Brompton and Harefield Hospitals Trust. We have now recently merged with Guy's at St. Thomas's Hospital to form one of the biggest trusts in the UK, and that gives us obviously an even bigger opportunity to serve you with our services. Now, while preparing this talk, I actually went back through my old presentations, and I was remembered that in the year 2002, so 20 years ago, I actually had organized a Marfan Day in Germany. And that was near Freiburg. You see here the lady with the hat in the Black Forest, and it was 6th German Marfan Tag. It was called Live with the Marfan Syndrome. And those days were very early days still. But we already discussed what we can do about our Marfan patients, how we can basically make sure that they can live a normal life. Now, it's nothing new that we are dealing with issues of the aorta. If you look here, King George II died in the year 1760 on the 23rd of October, suddenly of a ruptured aorta at the fortunate age of 77 years old. So he definitely didn't have Marfan, but you're not alone with it. If you look at this gentleman, you probably all remember who this is. He's now, unfortunately, he was murdered at a very early day in his life, but he's now sitting in the Capitol, and it's Abraham Lincoln. Abraham Lincoln was supposed to be having Marfan syndrome. There are some doubts about it nowadays. But he definitely gives the recognition of somebody who had a connective tissue disorder. So this is a long ongoing story. If you look into the epidemiology, then about 20% of all individuals with thoracic aortic disease actually have some genetic background underlying. So it is a very, very common issue we deal with. So what is so important about the aorta? The aorta is simply the highway of life. It's commuting all over the body and starting at the aortic valve, and it's running through the chest down into the abdomen. It's connecting all organs in our body, and anything that happens to the aorta will therefore have an impact on our life far more than we expect. There's a very nice painting which I always show, and I actually have it in my office. It's painted by Stephen Legoski, who is a contemporary artist, and it's called The Aortic Dissection. if you look at this, then you understand what actually happens if patients come into this absolutely terrific situation where the aorta splits. So here's the aortic valve. This is an aneurysm of the ascending aorta. And as you see, the aorta is split and everything in the body is basically involved in this split of the aorta. Lucky if you survive it, but this is what we need to prevent in all circumstances. That is where we aim for. We do not want to get to the point where this happens. Now, why does this actually happen? Why does it happen more often in patients who have connective tissue disorder? If you look at the normal wall of the vessel, it actually is contained of 3 layers. It's an inner cell lining, which is the intima. Then comes a connective tissue layer, media, and then a muscle layer. In patients who are suffering from connective tissue disorder, this middle layer is very fragile, and it can rupture and basically can end up in perforation and then bleeding between these walls, causing what we call a dissection. Now, the cardiovascular complications, they account actually for a significant proportion of the shortened lifespan of Marfan Trust patients. And aortic dissection is the most dreadful complication. Why does this happen? It happens often because the aortic root dilates initially in Marfan's patient, and this is almost every patient who is suffering from this connective tissue disorder. And it can lead then to aortic regurgitation, and in the combination with dilatation and regurgitation, it causes a substantial risk of aortic dissection. Now, what is the chance and what do we need to understand from the growth in the patients who are suffering from aortic dilatation in Marfan's? If you look at the diagram on the left here, you see that here the aortic size, the root, and here the estimated aneurysm growth rate per year. If you look at a normal aorta here, between 3 and 4 centimeters, the estimated growth of the aneurysm per year is somewhere between 0.2 and 0.3 per year. The moment the aneurysm is getting larger, like here over 5 centimeters or even 6 to 7 centimeters, the growth rate per year intends in faster growth per year. So any person who has a dilated aorta and the dilatation goes over a certain diameter, the growth rate is intensely going up per year. Therefore, it needs to be addressed and needs to be monitored even more closely, or an intervention is necessary. Now, what happens in the aorta is increasing in size. When does it basically rupture, dissect, or when anything can happen? And here again, this is a growth rate per year. The normal aorta 0.05. If you go over 5 to 5.5 centimeters, 0.15 cent increase per year, which means that you need to have very close monitoring, or you need to have an intervention. Now, what is the estimated effect of an aortic root aneurysm and the risk of a complication like a dissection or rupture? Here again, if you look at the size of the aorta, and this is the percentage increase in the probability of a complication due to the increased size, then you see at a normal diameter, it's almost 0, between 3.5 to 4. Then it goes up in the range between 4 and 5 centimeters to 15% more increased risk. And then comes this dip, and this is very interesting. This dip is a statistical result of statistics, because this dip is a result of patients who are rupturing or dissecting with a normal root. So it is actually not true. It would go up here. And if you go over 5.5 to 6 centimeters, your risk is extremely high that you rupture or dissect. So anything above 5 centimeters here leads to a high increase in risk of rupture or dissection. I will get to that later. Now, in a normal patient, the aorta always grows over a period of lifetime, but in patients with Marfan syndrome, it tends to grow 0.26 centimeter per year. So this is an increase that is significantly faster than in non-Marfan patients. Therefore, they need to be closed very closely, and you need to have a yearly, usually, if not even 6 months interval in patients who have a dilated root, because it is actually predictable that they will increase in size very quickly. Now, it sharply increases in risk at a diameter of 5.5 to 6 centimeter, which is the definite endpoint of an intervention in a patient with Marfan's. Now, what does that mean? Do we actually want to come to 5.5 or 6 centimeters? No, we don't. Because obviously, as we've seen, the risk increases 3 to 5-fold. Therefore, preemptive surgical intervention before we get to that point in Marfan's patients are adjustable and need to be taken. Now, coming to the options we have to prevent this dissection or rupture in patients. If you look at the typical aorta of Marfan patients, you always find this kind of configuration. The aortic root here, with the heart cut out of this image, coronary arteries are going off on the left here and on the right, is dilated. In this case, 44.5 by 43.7 millimeter. Normal in this patient would be somewhere between 3.5 and maximum 4 centimeters. The ascending aorta is normal, as is the aortic arch and the descending aorta. This is the typical configuration you find in the patient with Marfan syndrome. What does that lead to? If you look at the normal aortic root, the aortic valve is suspended in the aortic root. The aortic annulus here with the heart is basically connecting to the aortic root. The aortic valve can close and open without any kind of regurgitation. As soon as the aortic root dilates, the valve gets under tension and it flattens up. The aortic annulus dilates, and at the end point, because of dilatation of the root, the aortic valve cannot close properly anymore, and you end up with moderate or even severe regurgitation of the aortic valve, causing even more of a problem to the aorta. This is the typical mechanism we find in patients with Marfan's syndrome. Now, what are the indications for surgery? There are clear guidelines by the European Society and American societies. I've just picked out the European. So the recommendation is surgery is indicated in patients who have aortic root aneurysm with maximum aortic diameter of 5 centimeter for patients with Marfan's syndrome. So patients with Marfan syndrome, cutoff for surgery is 5 centimeter at this stage, but there's a big but. We still consider surgery in patients who have aortic dilatation and Marfan syndrome in patients who have family history of dissection or rupture, in patients who are having aortic regurgitation or any problems of the aortic valve, or need mitral valve surgery, and the cutoff is already 45 millimeter. And this is where we nowadays actually consider surgery for patients with Marfan's syndrome to be indicated at 45 millimeter. So we're not waiting until they're getting over 5 centimeter. We intervene very early. It is very important to understand this because that is basically preventive surgery. We want to prevent dissections, and we want to prevent ruptures and the chance of regurgitation. So what are the options for surgery nowadays? There is the traditional option of a so-called ventral operation with mostly a mechanical aortic valve included in this. This is the traditional operation that was invented to replace the aortic root. Then there is the valve-sparing aortic root replacement in two ways, either a David operation or a Hoop operation. And there's the Ross operation, which is basically an operation where the primary valve is implanted into the aortic root, and then the primary root is replaced with a homograft and the piercing procedure. So this is our repertoire we can offer patients for aortic root. What is the best option? There is always a big discussion around. Traditionally, the mechanical valve replacement was the best option, but it obviously does not really go with our modern approach to the replacement of the aorta. The gold standard since the 90s in high volume centers who are able to basically perform this operation is valve sparing aortic root replacement. The patient keeps his own valve, but the aortic root and the ascending aorta is replaced with a tube graft to prevent the rupture from the aorta. This is the gold standard that is offered to patients with Marfan syndrome or other syndromes, or even so-called normal patients who have a normal functioning aortic valve and need a root replacement. It is a technically demanding operation, but in good hands, it leads to excellent results. So when would we do still nowadays so-called dental with a mechanical valve? Only really in cases where the aortic valve, which is here shown, is tethered or cannot be repaired. This is the only real indication in younger people who have Marfan syndrome where we nowadays would still use a mechanical valve with a tube graft, because this valve obviously would not work for a long time, and a reoperation would be probably necessary within a short period of time. This is the left indication for patients who need a valve sparing root replacement. What we do nowadays is this valve sparing root replacement. As I explained before, it is a technically demanding operation, but the patient keeps his valve. The aorta is replaced with a tube graft that is sutured to the aortic ventricular junction. The coronary arteries, as in the dental operation, are reimplanted. The patient does not need any medication for this operation. There is no need for anticoagulation whatsoever, not even aspirin. It looks a bit gruesome here, but I wanted to show one picture, even though Anne told me not to show any blood, but sometimes it's necessary. You see, this is an aortic valve here, which looks absolutely normal. The aortic wall has been completely resected. These are the arteries to the heart, the coronary arteries. And it would be a shame to take this valve out and implant a mechanical valve. So at the end, you see here, it's all replaced. So the dangerous part of the aorta is now the dacron graft, the arteries are here, the human valve is sitting in here. And this will basically lead to an excellent result. I will go to the result there. So this is the gold standard which we would offer. Now, the perioperative mortality in these operations in experienced center is less than 1%. And the freedom from reoperations in patients who are not suffering from connective tissue disorder is about 1% per patient year, so it's low. Unfortunately, in patients who have Marfan's or other connective tissue disorders, there is a chance of 17 to 20% in some serious necessary reoperations. But that is depending on the technique one adjusts to the operation. In our hands, the reoperation rate is about 1% in these patients. So it's very low. if you look at this chart here and you compare the results of the valve-sparing root replacement here over a period of 20 years and the replacement with a mechanical valve conduit, and you look at the long-term survival is much better in the valve sparing than in the mechanical valve. This is not a technical issue with the operation. It is a result of anticoagulation with warfarin and obviously possible complications with the mechanical valve like thrombosis or others. So the aim is nowadays to keep the valve sparing. Okay. Now, if you look at the number of reoperations, there is not a big difference between valve sparing root replacement and mechanical valve replacement, but still the valve sparing operation is slightly better. So there's a 95% freedom from a reoperation over almost 20 years, which is an excellent result. Now, another very good way of preventing further dilatation or dissection is the Pierce procedure. This is an operation that is basically performed to prevent the dilatation, to prevent the risk of dissection, to prevent aortic regurgitation, or even shown now by surgeons like Conal Austin and Dyson St. Thomas's, it can reduce, why not even abolish, aortic regurgitation in patients who have mild to moderate aortic regurgitation. Now, it's a new concept. It's not really new, but it's been developed by Tal Goldsworthy, John Pepper, over the last 20 years. The idea is that not touching the aortic valve, we're not touching the aorta. What we do is we basically wrap the aorta with a custom-made special tube around the aortic root, around the ascending aorta, that is created as a result of a three-dimensional reconstruction of the patient's aorta, as you see here. So we basically conduct a special CT angiography of the aorta, where the patient's aorta is exactly measured in three-dimensional way. Then this 3D form is created, and around this former, this mesh graft is then created, which basically is the form of the patient's aorta. And then during the operation, this mesh is put around the aortic root and ascending aorta and closed above it, so that it basically sits here from the aortic valve up to the ascending aorta, brachiocephalic trunk to the aortic arch, preventing a dilatation of the aorta and obviously stabilizing the wall. Now, the good thing about this operation is obviously you do not touch anything around the aortic valve, so the anatomy of the aortic valve stays the way it is. If the aortic root is already dilated with leading to the regurgitation, which I showed before, then it can be reduced by basically closing the aortic or decreasing the size of the aortic. The last and latest publication just is in press, and the results are very comfortable. So there's a total population of 200 patients. 194 the Pierce was completed, and 5 procedures needed to be converted. There were basically 185 patients doing very well after the Pierce procedure. Out of the 200, there was one intraoperative death, leading to a mortality of 0.5%. And 3 reoperations. So this is very encouraging if one looks at that. If one looks at the table of freedom from reoperations. This is the red line here, and survival. If you look over this period of time, the needle had to be cut off at 9 years, as the number of patients fell under the statistical number. It's very encouraging. It's basically mirrors the survival and the freedom of reoperation in valve-sparing root replacements. And the next 10 to 15 years will give us the answer whether this goes on like it and whether we basically can endeavor on this operation in a broader way. Now, coming to one point that is probably interesting to patients who already had suffered aortic dissections. As I mentioned, this is what we want to prevent. We do not want our patients to suffer a dissection, because if you look at this diagram, it makes a huge difference. The blue curve up here, up there, and up there are patients who have aneurysms, so dilated aortas, but they never have suffered a dissection anywhere in the aorta. The red curves are patients who have suffered dissections. And this not only includes dissection of the ascending aorta, any dissection downstream. And if you look at the freedom from reoperations in the aortic arch, which is the next part of the aorta, and this is a very dangerous operation in the way that it involves circuitry arrest, it's a big operation. People who never had a dissection but had an aneurysm and were operated for that, they basically hardly need any other operation there. Whereas if patients had a dissection, then you can almost admit that 50% will need another operation at a later stage. If you look at the survival, which is even more important, patients who have been operated for an aneurysm, their survival stays basically and goes with the normal curve of survival in the normal population, whereas patients who had dissections, they slowly go down, and the 20-year survival is only like above 75%. So again, very important to prevent the dissection. If we look at the progression and reinterventions of patients, does it make a difference whether you have Marfan syndrome or whether you do not have any connective tissue disorder once you have suffered a dissection? And interestingly, there is no difference. So whether you are suffering from Marfan's, Loeys-Dietz, Ehlers-Danios, or whether you are not suffering from connective tissue disorder, at the end of the day, once you had a dissection, you go the same way. The blue curve is patients who have no variants found in their genetic testing. Red line here is patients with connective tissue disorders. As you see, the difference at the end of the day is statistically insignificant. So it is something that needs to be prevented in any. What are we doing with reoperations? As I said, what happens quite often, if you had a dissection, other parts of the aorta will need another operation, and mostly is in the aortic root. We have to often reoperate the aortic root, or we have to reoperate the aortic arch, which nowadays is a standard operation. Nevertheless, it is still a big operation, but we've improved on our techniques in this field. So what we nowadays often do, and this is a nice drawing, my senior registrar, who is a real artist, always likes to draw when we do these operations. What we do nowadays, if we have to reoperate or have to replace an aortic arch replacement, we basically reconstruct the anatomy completely with our repertoire of grafts we have now. This is a so-called frozen elephant trunk. I will come to that in a minute. So we replace the entire aortic arch with a graft that is connected to the stent of these grafts and come off side pipes, go up to the neck. As you see here, we connect all the vessels to the brain, carotid arteries, the subclavian arteries, then the stent goes in here. So basically, we are able to replace everything with results. Or we do these fancy operations where we basically build a zone of Dacron because we cannot go further down to the aorta, then connect all the vessels with other grafts, and then later come with a stent and overstent this. So this is all possible nowadays with very good results, and very happy about that. The frozen elephant trunk is what we do nowadays. Looks like this. It basically connects the ascending aorta from the root into the vessels of the brain, into the descending aorta. It has a long history. When I did my first operations with the frozen elephant trunk, there's somewhere here. It was quite a dangerous operation, and it basically had a very, very high mortality, over 30%. It was technically demanding, and the end results were not very good. So we ended up with having like prostheses fluttering around in the aorta. It's quite horrendous. But nowadays we've got the technology. It makes it a lot easier and much better for the patient. Now, often the patient needs further operation, but what we do not want to end up in patients with connective tissue disorder is something like this. Here, this is a patient we had to reoperate 4 times. And because he was so frail, we then had to put in stents. Stents are inner scaffolding of the aorta, because his entire aorta was basically replaced from here to the ascending aorta into the arch. And this is a configuration that is possible, but in patients with connective tissue disorders, we are still in very early days, because these stents, they have a lot of radial force, and they can cause problems in an aorta that is not stable. And what we end up often is this situation where we put in a stent, and then months later, the stent, because it's a metal frame, erodes the aortic wall and basically leads to another aneurysm. So presently, we are not really at the stage where we would recommend TEVAs, which are thoracic endovascular aortic repairs with stents, or EVAs, as a routine procedure in patients with Marfan's syndrome. Here again, the intervention, and I don't want to go too much into it. What is important to understand is obviously patients with Marfan syndrome who need aortic surgery often need mitral surgery at the same time. And that has quite an impact on the long-term outcome in these patients. So if you look at patients with aortic events, that basically follows the normal route of survival in the normal population. But the blue line here is the line where patients do not need any mitral intervention. The red line is the line where there is mitral valve intervention necessary due to a specific situation where the mitral annulus is disjunct. That means it's in a different position than normal from the aortic valve. This needs to be monitored extremely well. It's a finding we actually found out over the last couple of years. It's fairly new. It has nothing to do with a Barlow's valve that is typical found in patients with mitral valve. It's more the annulus, so the frame of the valve. If that is disjunct, and the chance that something like an aortic dissection or aortic dilatation is happening earlier is largely increased. So that is something we are looking at now very specifically in all patients. As soon as we see that there is mitral annulus disjunction, we intervene far earlier than other patients. Coming to what is important to understand for a lot of patients is pregnancy and aortic complications. This is something we are looking into it more and more. And the most serious complication in patients with Marfan syndrome during pregnancy is an aortic dissection. This is substantially increased during pregnancy and the postpartum period. And that has something to do with the rise in blood volume, heart rate, stroke volume, and hormones changes during pregnancy. And it is the most frequent cause of pregnancy-related dissections. So patients with Marfan syndrome need to be extremely well monitored during pregnancy and should be actually monitored before they fall pregnant. I strongly recommend that. If you look at the rates of aortic complications in big studies, they have an average of 4%, so between 2 to 6%. The expected rate of aortic dissection is only 1% in the normal population with an aortic diameter under 40 millimeters. But as soon as the aortic diameter goes over 40 millimeters, women pregnant and Marfan's, the 10% risk of having a dissection during pregnancy. So it is extremely important that the aorta needs to be monitored, and that when you want to fall pregnant, one investigates this before you fall pregnant. That would be really helpful in order to get the right monitoring going, or even to possibly do a preventive surgery, like possibly a Pierce procedure, maybe a valve-sparing root replacement, whatever is necessary in order to prevent the 10% risk, because it is a high risk. And we've done investigations on that, and we have very good center next door, Chelsea Westminster Hospital, who will help with that. What is important to understand, and I wanted to come to that point at the end, besides anything else, what happens if you fall pregnant and you have a mechanical valve conduit? So you had an operation years ago, and because of whatever reason you needed a mechanical valve implanted, and now you want to fall pregnant. Is that possible? And what risks are involved? It is possible, but the problem with mechanical valves is that you can never stop the anticoagulation. And the usual anticoagulation that is necessary is vitamin K antagonists, or warfarin. And warfarin during the first 2 trimesters is highly teratogenic, and it can lead to bleeding in the fetus. It has a high complication rate. So there are different ways of preventing or dealing with this. So what we are doing at this stage, we give the patient low molecular weight heparin as an anticoagulant. We stop warfarin and we monitor it very closely. Other centers, like the center we did this study with, the Erasmus Medical Center, go on with warfarin on a low dose and add heparin. It is possible, but it has a high complication rate for the fetus. And unfortunately, with whatever way you anticoagulate, you might end up with fetal death at the 2nd or 3rd trimester. So it should be, if possible, prevented. But it is possible, but it needs to be done in centers that have the experience. You cannot be in a just normal obstetrics and gynecology, but you need to come to a center that has experience with dealing with these patients. That's why what I suggest, and what is the guideline, is if the aorta is under 40 millimeter in patients with Marfan, you're quite safe. So you can basically fall pregnant without having major investigations or major planning. If the aorta is 40 to 45 millimeters, so intermediate, you need a follow-up during the end. You would consider cesarean section. If the aorta is already over 45 millimeters, you want to fall pregnant, we strongly suggest that you should have preventive surgery before you fall pregnant. If you are over 45, you are pregnant, it needs to be monitored in a center that has the experience and cesarean section. But the best way of dealing with it is if it's over, your aorta is over 45, that it should be preventively operated, as I say, either with a Pierce procedure or with a valve-sparing root replacement. Then you're safe and fine. Coming to the end, so unfortunately, multiple subsequent procedures may be necessary in patients with Marfan syndrome, and they need to be dealt in a center that has an aortic team. There needs to be an aortic team that has cardiac surgeons, vascular surgeons, interventional cardiologists, and radiologists in order to cover the entire field, because it's not just the aortic root or not just the aorta, it's the entire vascular system. If you are on teams like that nowadays, you are safe. Thank you very much for your attention. On the left, you see our aortic team. So it's quite a big group of surgeons. That's not even involving everybody. It's, we've got the two sides, the Brompton and Harefield, and we're trying to do the best for you. Thank you very much.
Thank you so much, Mr. Rosendahl, for your most encouraging talk and telling us about the modern options for surgery, which improve and get safer all the time. Most encouraging is the low risk if one can operate preventively. And I would encourage all our patients and their families not to be afraid of surgery, but to come forward, and then the surgeon is given a fair chance to do his best. We have time for perhaps one question from a patient. If somebody were to collapse in the street with an aortic aneurysm, would applying CPR compound the situation life-threateningly? What would you suggest?
If somebody collapses in the street and he has an aortic dissection, you have to resuscitate the patient. You have to do CPR, because that is the only way of keeping the blood going through the body. There is obviously always the chance that you might increase the rupture, but if you don't do chest compression, the patient will most definitely die, because the mechanism of sudden collapse in aortic dissection is that blood comes out of the aorta, and usually it's not a real rupture, it's just trickling out, and it's filling the pericardium, which is the bag around the heart, compressing the heart, and then stopping the heart to be able to pump the blood out. So the only way to basically keep circulation going is during chest compression. There is a chance that you rupture, but if that happens, if you collapse on the aortic dissection in the street, in any case, the mortality is extremely high. So the only chance to do it is start CPR.
Thank you so much. And a lot of your patients must come from a distance for heart surgery. Can you tell us how you organize their care before and after? Do you usually have a home team of cardiologists and physician, and you collaborate with them? What can they expect post-surgery?
Yes, we've got a whole Marfan clinic. I mean, it's not surgery only. Surgery is kind of the technical part of the procedure. So patients coming from all over the place, they come internationally, they come from all over England. What we do is we obviously have a specialized Marfan clinic. We've got a specialized genetic service. We've got a nurse lab clinic. So they are monitored. They are kept under surveillance frequently. They're always seen minimum once a year after any kind of surgery. They're seen before surgery. They're discussed in our multidisciplinary teams meetings. So we're not losing, specifically Marfans or Loeys-Dietz or Ehlers-Danios especially, we don't lose to follow up. The good thing about patients who are basically having Marfans or any other connective tissue, they're well organized. Like the Marfan Trust helps a lot with it. They know what their problem is. They know that they're not just having an operation. They look after themselves very well. So this makes our job a lot easier. They often come back to us and actually ask us, when can we come back? So, but this is all well organized. So it's the whole teamwork.
Thank you so much. I think we're going to have to move on because of time pressure, but I'm sure you're all grateful that Ulrich has given up his Saturday morning for us. And thank you so much.
Could we speak
Pleasure.
one further question?
One quick one, yes.
It's a parent of a 15-year-old boy who has Marfan syndrome and aortic root, which is 42 millimeters last year. He's to have his MRI and echo this December. How likely is it that he will require surgery soon? How intensely should he be monitored? He's a patient at Gosh.
So he's 15 years old, and that's the diameter of the root, which is quite dilated for a 15-year-old. Strongly recommend that he has, because he's in the growing phase of his life. That's the issue. That he's been monitored 6 monthly, echocardiography. If the root is stable and is not increasing, then one can reduce it to once yearly. But one needs to monitor it closely at that age, because it's not predictable what is going to happen in the next 2-3 years while he's growing. So this is a very important phase of life. If you look at the diameters of the aorta in the so-called normal population growing in the first 20 years, it's exponentially bigger than later, and that's for obvious reasons, because grow. So that needs to be monitored closely. If it gets, that is the whole discussion, obviously, it will get bigger, well, that's absolutely predictable. The question is when and how should one intervene at some stage. But at the moment, it needs to be monitored.
Thank you.
Thank you. That's my question.
It's very important to understand that the aorta, in the population who doesn't have connective tissue, is decreasing in size with over a lifetime. That's normal. Now, the problem with Marfan's or any other connective tissue disorder is that it's going exponentially up. It's predictable. So the only way to prevent dissections or ruptures is to intervene. That's why don't be afraid or scared of surgery. That's actually what saves your life. You're not dying of Marfan's because you've got a lens dislocation or because you've got scoliosis. If you die of Marfan's, you die because of an aortic disaster. That is preventable with very, very low risk.
Thank you. That was my question. My son is on preventative, losartan and beta blocker as well. So
that's important.
Thank you so much.
Thank you.